Hello and welcome to Drip Symposium. My name is Clayton Grigsby. In this slideshow, we wanted to define fluid management and everything that entails this subject to get a really good understanding of what fluid management is. This is my disclosure screen. I'm employed as a principal medical science liaison for Baxter, and I've been a registered nurse for quite some time, almost 10 years. I spend most of that time in the ICU and also in educational environments as well. All right, so the objectives for this slideshow is to really define and discover the many terms associated with fluid management. There's a lot of terms out there, a lot of studies use different terms. It gets really confusing really fast. I'm really hoping in this presentation that we can really map those out and gain a really good understanding what each term means. We want to explore the basic principles of fluid management. So how do we do it? What's the basic maneuvers that we need to do to gain the information if our patients can tolerate fluid or not, right? So next is discuss the different technologies, how they work, and what are the contraindications. It's not always one technology fits all patients. So we definitely want to make sure we're using the right technology for the right patient. So to get really successful at fluid management. All right. All right, so we're going to get into some terms here. This is the defined portion of this presentation. So there are some basic terms in hemodynamics we really need to understand to be successful here. I don't want to make it too hard. I want to make it really easy, actually. But there are a few we need to know, beginning with stroke volume. I think stroke volume is the most important term that we need to understand. And what is stroke volume? Stroke volume is the amount of fluid coming out of the heart per beat. So as you can see, as the heart beats, it's the amount of fluid that comes out. Normal stroke volume is 60 to 100 milliliters per beat. In my practice, I always like to use stroke volume index. So stroke volume index is similar to stroke volume. However, we're factoring in body surface area to this patient. And what that does with stroke volume index is we can individualize this number very well and get kind of a tighter parameter for the patient. Again, stroke volume is just the amount of fluid pumped out of the left ventricle with every beat. Okay. So cardiac index, cardiac output, again, with these index numbers, cardiac output is the amount of fluid coming out of the heart per minute, not per beat, but per minute, right? So to get that equation, we get heart rate times stroke volume equals cardiac output. Again, we can index this number and factor in body surface area. So normal ranges of a cardiac output is 4 to 8 liters, but if we want to individualize that number very well, we can go to cardiac index, which is 2.5 to 4 liters per minute per meter squared. And that's just factoring in body surface area again. Now, one thing I always try to ask students when I talk to them is, can you have a normal cardiac output but a terrible stroke volume? And if you're thinking right now, the answer is yes, you can have a normal cardiac output and a terrible stroke volume. How is this possible? It just means that your heart rate is compensating and getting higher. So this is early shock states. So when we see our patients and their heart rates are just shooting up, of course it can mean a lot of things, but we really need to dig deeper and to see what's going on. Is our patient going into shock? Are they not? This is a good indicator that a patient is probably in duress. All right, so preload. Preload is when the fluid comes into the heart and it stretches the ventricles, as you can see here in this animation. Preload is what we're trying to do when we give boluses. We can manipulate preload by giving a bolus. We can also manipulate preload by maybe diuresing our patient as well and subtracting the amount of fluid that comes back to the heart, right? So preload is not always a good thing. If we get too much preload, obviously it leads to fluid overload. We want to be really careful with preload, and when we manipulate the patient, we want to make sure we're really using good fluid management practices to make sure the right amount of preload is going to our heart to cause good performance. We have contractility. So if preload is the stretching of the ventricle, contractility is definitely the contracting of the heart. So when our heart contracts, how hard does that work? We can manipulate this as well, right? So we can manipulate this possibly with like a positive inotrope, for instance, and we can get that contractility working better for us. So this is something that we really need to look at. Cardiac output right now is the best parameter that we have for contractility. So when we're looking at contractility and we have worries about contractility, cardiac output is definitely what we're trying to, the number we're trying to move. All right, so, and then we have afterload. This is the one people usually get wrong. They want to associate with preload, so that's fluid coming in. Well, afterload is not the fluid coming out. It's actually the resistance the heart has to overcome to eject blood out of the ventricles. So I put two examples here before we get there. Sorry, our normal ranges for total peripheral resistance on top is 800 to 1200 dynes per second per centimeters. Then we have TPRI. I like again, I like my index numbers. That's 1970 to 2390 dynes, right? So, and that's just factoring in the patient's body surface area again. Now on the left and the right, I have two examples here. So on the left, this would be more like septic shock. That heart's not beating so hot. We don't have a lot of resistance, so there's not a lot of tonality into the vasculature. So if I took like this would be an example of like a septic shock. If I took a measurement of TPRI, it would be pretty low, like 900 dynes. So we got to be really, really cognizant of this. Is it a pump problem or is it a pipes problem, right? So if I have a patient with the dynes of 900 dynes on my TPRI, definitely I'm looking toward a medication such as a pressor that could probably fix that for me. On the right side, we have cardiogenic or hypovolemic shock. They both interact the same way with the heart, as we have a lot of resistance. Obviously, it's having a really hard time to eject blood out of that heart. Obviously, TPRI, the measurement on this patient would be somewhere around 4,000 dynes, just for example. Things we could do to fix this patient is we could start maybe a positive inotrope, like dobutamine or something like that, right? So we can vasodilate and also get the contractility of the heart up. It would fix this the shock state. Okay. One thing I want to say on the side here is total peripheral resistance index, TPRI, and systemic vascular resistance index, SVRI, are very similar. Both are measured in dynes and have the same normal to abnormal ranges. The biggest difference is TPRI does not factor in CVP like SVRI does. However, when I was using maybe, the old school days, when we were using like the old CCO machines, or if we were using the, other technologies that are newer, a lot of the reps would always just tell me, hey, just put in 10 for your CVP if we don't have a CVP measurement. So what does that mean? That means the CVP doesn't really affect the number that much, and that's why we can have the same normals and abnormals as well. All right, so we're still continuing along with the define here. We're looking at dynamic assessments, and how do we do that? So there's two choices that we have currently that we can do a dynamic assessment to see if my patient needs more fluid or not, right? The one on the left is called a PLR, or a passive leg raise. And the one on the right is a bolus challenge. So really what we're just trying to do is introduce preload to the heart to see if it has a response. Is the stroke volume going to go up? Is it not? Right? So dynamic assessment is utilizing dynamic maneuvers to assess fluid responsiveness, for example, right? So let's get into the passive leg raise, right? So here there needs to be a baseline stroke volume established. So when we conduct a PLR, we can see how the stroke volume behaves from baseline. So usually we start out with a patient with a head up at 45 degrees. We're really pulling a lot of that fluid down into the calves. Usually whatever technology we're using usually has a protocol for this and really steps you through the passive leg raise. What we're waiting for is after about usually 3 minutes of baseline, what happens is usually whatever technology we're using will tell you to put the patient in another position. which should be this position. So as you can see, we went from a baseline phase to a challenge phase, and now we have the legs up with the head down. And what's interesting about this is now we get fluid that comes from the legs down to the heart. Once a successful baseline is established, patient is placed in this PLR position for the challenge phase. And what does that look like? Again, we have that fluid that we pulled in the calves is coming to the heart, creating a bolus of the patient's own blood. And what's cool about that is we didn't add any fluid. So if the patient is not fluid responsive, for instance, no harm, no foul. We can just sit them back up. We didn't expand the venous volume or arterial volume as well. So this is pretty cool. When conducting a PLR, we translocate about 250 milliliters of blood from the legs to the heart, creating a bolus out of the patient's own blood. Again, right? Passive leg raise is an excellent diagnostic test. So as we can see, here's a couple studies below. One done by Dr. Binster and one done by Dr. Monet. And what they found was a highly accurate test. I mean, it had a ROC of 0.95 on the PLR. So as we can see here, we have a patient in the baseline position. We have our baseline stroke volume. As a patient was put in the PLR position when prompted to, obviously, stroke volume rose. This would possibly be a fluid responsive patient. As my patient was placed back into the baseline position after the diagnostic test, we can see we went back down to baseline. And what's kind of cool is this was predictive what would happen if we gave fluid, right? So as we infuse 500 milliliters of saline, this stroke volume rises and stays there. And that's what we're really trying to get with our patient when we're looking for fluid responsiveness. This would be more of a healthy patient. Now, if we didn't have a fluid responsive patient, possibly when we have the baseline, we get our baseline, we put them in the PLR position, we wouldn't see a rise here in stroke volume. We'd actually would see it be kind of shallow or even a dip sometimes, right? And if we were to give that patient that 500 milliliters of fluid, then we would see probably a decline in stroke volume, which is what we don't want to see. So one thing, it'll probably be repeated in this presentation throughout the multiple presentations, but the only reason to give fluid is to increase stroke volume. There's really no other reason to give fluid. And what does that mean? We'll discuss that more here in a second. All right, so passive leg raise. There are contraindications for PLR, passive leg raise. Obviously, if we have amputees, that's a problem. There's no blood to translocate, right? So hip fractures or trauma, I've had people with spinal fractures or hip fractures. They can't be moved around like we would like them to be. So obviously, that's a contraindication. Increase of intracranial pressures. That's a big problem. Obviously, laying flat would increase that. That would be a contraindication. And immobility. Now, I just kind of put this as a general phrase, immobility, but really pay attention to your doctor's orders. Some patients have sheaths or they have, non-movement orders where we can't actually position our patient. So we need to be really, really cognizant of our doctor's orders and making sure we're doing the right maneuver for our patients. Now, if we cannot do a PLR, as discussed before, we can do a bolus test in lieu of the PLR. So if the PLR cannot be done, then we just don't do it, and we do the bolus test instead, right? And let's go forward and talk about what the bolus test looks like. So again, we still have to have a baseline phase, right? Just like the PLR. We need to get a stroke volume established, a baseline. So when we conduct a bolus test, we can see how the volume behaves. Especially the stroke volume behaves when we give more preload, right? Unlike the PLR test, during the bolus test, patient can be in any lying position. This includes prone as well for the baseline and the bolus test, all right? So it's not position specific. The positioning of the PLR is to get the fluid and have gravity help you bring it to the heart, creating a bolus. However, if we can't do that, we need to create the bolus externally with a bolus test, all right? All right, so as we go along, what does the bolus test look like? So look at this animation. As we have fluid draining out of this bag, it's obviously going up through the IV and going into the IVC, going into the heart, and it's coming out the other side. Once a successful baseline is established, we can introduce either a 200 milliliter bolus in under 5 minutes or a 500 milliliter bolus in under 10 minutes. to see how the patient's stroke volume behaves from baseline, right? So one thing I really want to point out here is 999 on a pump will not work. It's just too slow. We need that bolus to go in really, really fast. So the bolus needs to go in maybe under a pressure bag or something like that to get it in fast. That's usually a pretty popular choice. All right, so this is an example of a fluid responsive patient. So as that fluid's coming in, I use this quite a bit. So one thing we need to really understand is only 50% of patients are hemodynamically only 50% of hemodynamically unstable patients are fluid responsive, right? So that's a big deal. So what does that mean? That means as I give fluid into an IV, right, and that fluid moves to the heart, I had better see it come out the other side of the heart in the form of increased stroke volume. So obviously this patient right now, defined fluid responsiveness is as any patient over 10% growth under stroke volume or stroke volume index, and from baseline. And that's what we want to see. So remember, the only reason to give fluid is to increase stroke volume. And that's what we're seeing here with this fluid responsive patient, right? Fluid responsiveness alone, this is in red. Fluid responsiveness alone does not mean give fluid. There has to be a need, right? So what does it look like when a patient is not fluid responsive? Obviously, we see a lot less fluid moving forward here, possibly a lot of it backing up. We did not see an increase of stroke volume greater than 10%. And if we were to go ahead and give fluid to this patient, we can see what the detrimental effects are right here. So we start introducing maybe pleural edema, maybe other things, maybe going back further through the venous system, creating backup through the kidneys and stuff like that. So giving more fluids to a patient that isn't fluid responsive would likely drive complications. So one thing I always implore nurses and physicians and APRNs is when we're ordering fluids, will that fluid benefit my patient or will it likely drive complications? We want to make sure of that, right? So there are studies out, well, I think it will be presented in the next presentation, that shows excellent outcomes when we are good stewards of this practice. So one thing I really want to make sure we're doing is we need to check if our patients are fluid responsive before we ever give any fluid at all. And this will give us greater success to the outcomes of our patient. If the patient's not fluid responsive, likely early vasopressor support would be the best treatment option for this patient to restore hemodynamic stability. All right, I agree with that. All right, so here's another patient is not responsive to fluid. So obviously we have fluid coming in, not a lot coming out. So sometimes we get negative numbers. So I get a stroke volume, let's say, I get a baseline, and then once my test is done, actually stroke volume fell from that baseline. It gives me a negative number. A lot of people think those are erroneous, and that is not true. Getting negative numbers as a response is not erroneous. There is early research suggesting patients that exhibit a negative number response from a dynamic assessment could be an indication for RV-LV dysfunction. I would really advise you to follow up with an echo to see if we can get some diagnostics in there to see what's going on. This was presented at CHEST this year, I believe, by Dr. Ali Javed. And he did have this finding with a lot of his patients with negative numbers. So let's get into the Frank-Starling curve. So let's put what we've learned into action here, right? So as we can see here on the right, I have a patient, stroke volume index is 25, normal ranges is 33 to 47. So obviously this is a patient that's hemodynamically unstable, right? So if we did a passive leg raise on this patient, hopefully they're fluid responsive. Let's just pretend that they are, right? So the patient is fluid responsive. Let's see what happens when I give them some fluid. The behavior of stroke volume actually goes up the scale here, and we actually get to the patient to normal ranges. Notice that my SVI on top actually came up to 37, which is normal. And one thing we need to learn about the Frank-Starling curve is as I give more preload, what is the behavior of the stroke volume? As we could see, this patient actually rose to normal ranges, right? So let's say we did another dynamic assessment on this patient and they were not fluid responsive, right? What would happen? And if we choose to give more preload or a bolus to this patient, let's see what happens to their stroke volume. Obviously, we went to the very top point, and now our stroke volume is starting to fall. So this is where we start to get in the red zone here, right? So we definitely, if this patient was not fluid responsive, why in the world would we give them fluid? It actually gives them less performance. We actually have less fluid coming out of the aorta and more fluid that's backing up and possibly the lungs and especially the venous system, right? So we need to be really careful with that. So obviously, this would not be the choice for the patient. This would be actually more detrimental. So patients too low, obviously, are having too little stroke volume. Patients too high with preload is going to have failing or falling stroke volume as well. So we really want to get these patients right here in the middle. That's kind of where we get the most success. Okay, it's important to know that not all patients have the same Frank-Starling curve. So on the left here is an example of a normal patient. Maybe their Frank-Starling curve has this wide arc. Patient with a cardiomyopathy, example here would be like congestive heart failure. Maybe their Frank-Starling curve is very shallow. So if we gave, let's say, patients a 1 liter bolus, let's see what happens to their, this is just an example. This is not what happens every time. This is just an example. So side by side, 1 liter may give our patient on the left a pretty nice little fluid zone that we actually want to keep them in. But that same liter over here, this is why we always hear doctors maybe for CHFers order 250 or less fluid, because that 1 liter can span their whole Frank-Starling curve. Now, one thing I really want to point out to you, if you're an ordering physician or APRN or even a nurse trying to understand your patient's stroke volume, just because they have CHF doesn't mean they don't need fluid. So we still need to check them for fluid responsiveness. I see a lot of doctors and nurse practitioners really shy away from giving fluid to these patients, and they're underperfused, and it can really cause havoc on their body, especially with like organ death and stuff like that. So we really would need to make sure our patients are fluid responsive, and maybe a liter is the right choice for this patient, but over here, just being a little careful with this patient, maybe 250 at a time is what we need to do. Okay. So one thing I want to show you is when this would be a patient probably that's not fluid responsive, right? If we gave them more, obviously they would just keep coming up this Frank-Starling curve and stroke volume would suffer. But what's cool is it's important to note that some patients have less reserves on their Frank-Starling curve due to various disease processes. This doesn't necessarily that they have too much fluid on board. Maybe even the disease process brings them up, brings down the performance of their heart. Maybe like a substance-induced cardiomyopathy, for instance, which happens in over 50% of our patients. I think it's closer to 60% actually. So we need to be really cognizant of these patients. If this patient was not fluid responsive, we can start a pressor on there. So likely would not be fluid responsive. And however, the treatment option for this patient would be maybe pressors, right? And look what happens to the Frank-Starling curve when we introduce a pressor, especially like norepinephrine. Norepinephrine is the gold standard for septic shock. And the reason why is because we have both alpha and beta antagonist on that drug, and what the alpha does is it really squeezes our vessels, which we desperately need in septic shock, but the beta, what it does is it actually brings up contractility. So what's cool on the Frank-Starling curve is you notice it brought the patient down to optimal fluid zone. These patients are really kind of fun to play with. One thing I really like about this, and the fresh study that will be presented later actually showed this too, that our patients went in and out of fluid responsiveness in the first 72 hours of treatment, and mainly this was due to the introduction of norepinephrine. So norepinephrine can definitely just do that beta activity, can really, really bring us back down the Frank-Starling curve and give us more reserve. So that's one thing I would do with that patient is make sure do they become fluid responsive with the pressor on board? And maybe we can start balancing fluid in the pressor. All right, so let's discuss. So there's a lot of things we can do to look at fluid responsiveness. Now, there's a study called Baxter. He looked at around 2,500 patients, and what he found that with different modalities to look at fluid responsiveness is some were not that great. Now, the one that we use a lot And I will say early practice, this is back in like the early 2000s, there were people doing passive leg raise to see if blood pressure would have an effect, right? So we know that blood pressure compensates quite a bit. So we got to be careful with blood pressure. What Bensner found that blood pressure is only about 50% accurate. So I would advise you, please do not use blood pressure for your fluid responsiveness. It is just not a smart thing to do. I still see it happening when I visit hospitals, sadly. However, it is just not a good indication of fluid responsiveness. Next is CVP. I still see this used, and there's been trying to be a rebirth of this as well. It's only about 60% accurate, which was looked at the Benster study as well. And we really need to shy away from CVP for fluid responsiveness. It's just not, it's a really good indication of right atrial pressure, but not a very good indication of fluid responsiveness altogether. So we need to really shy away from that if we can. The PAC catheter thermodilution, fluid management can be done actually very well with this product, but it's invasive. So it really, I don't really see that we're putting a PAC catheter with every septic patient, for instance, like coming in the door. If we are, shame on you. There's better ways to do that. It's good practice, I understand, some teaching facilities, but we really need to start exploring some of these non-invasive or minimally invasive techniques to look for fluid responsive. That actually do a very, very good job. All right, so let's discuss some of the technologies here. So pulse contour technology is very, very popular. It's minimally invasive. It does involve an art line, especially some technologies. One thing that it really does is, as I have obviously a heartbeat that's coming down to my wrist, and that pulse comes all the way down, I have a transducer on my art line that actually gives me information to my device. So there are some limitations with pulse contour technology. Over or under dampened art lines, it's estimated almost 30% of art lines out there are over or under dampened. So this really affects accuracy, I should say. Low SVR, TPR states such as sepsis or liver failure. So we got to be really careful with that. It really does skew the numbers. SVR, TPR changes such as in vasopressor use. So if we have a patient maybe that's in septic shock, for instance, and is on some vasopressors, we really need to be careful with pulse contour technology. Intra-aortic balloon pump as well. So this is all contraindications for this technology. There's also a finger cuff. There's many companies that are coming out with these. It seems like it's maybe 3 or 4 out there. It's still pulse contour technology, but this is their non-invasive finger cuff. And how does that work? So we have a cuff that goes around the fingers and really settles the arteries. And we have an IR LED and a photodiode that is actually sending information in and is trying to get the pulse contour of the arteries in the finger. So that's it's giving us a waveform, obviously, with our little diacritic notch as well, and it sends that information back to our machine. Let's look at SVV and PPV for that matter. So stroke volume variation or pulse pressure variation. Stroke volume variation seems to be the most popular. I still see this used a lot. SVV is highly accurate, highly accurate. However, we need to make sure that our patients fit all the criteria for SVV and PPV. There's ways to do this. We can do arterial waveform analysis, pulse contour analysis, obviously esophageal Doppler and echocardiography with both TTE and TEE as well. So we can actually look at stroke volume variation in all these technologies. If there's a 13% variation, as we can see up here, this would be possibly when our patient is not getting a tidal volume pulled in, and we looked at the measurement there on amplitude meaning height, and when our patient actually goes in an expiratory stage of the ventilator, obviously it shrinks, and we want to see a variation of 13%, which is highly likely fluid responsive. If they're less than 13%, they're likely not fluid responsive. There are some big limitations to this, and these get commonly ignored. I will say if all the limitations are met, It's highly, highly accurate. However, when we do have limitations, we need to be careful with this. So your patients has to be intubated and sedated. They can't have any spontaneous breathing, right? So tidal volume of 8 milliliter per kg of ideal body weight, which is pretty high. That's a pretty high setting. We're getting pretty close to where it can cause barotrauma there, right? So no arrhythmias, so we need to have normal sinus rhythm, please, on this, and no open belly or thorax. So I see a lot of doctors ignore this one, no arrhythmias. I was just in a conference at ACEP, American College of Emergency Physicians, and a highly, highly decorated, highly renowned doctor was giving patient patient examples, case studies. And all the case studies, patients, heart rates were 120 AFib, all this stuff, but he was using SVV, right? Spontaneous breathing patients, right? So once we start peeling away all these limitations, our accuracy kind of goes out the window. So we need to make sure we're getting the right technology to the right patient. So post-contour technology, how does it work? Obviously, we have a systolic and a diastolic. We have our diacrotic notch there, and obviously this line in the middle is our map, right? So what we're really looking for is this systolic area under the curve due to amplitude, right? And that's generally how we get our signal with SVV or even pulse contour, right? When we do our dynamic assessments with these patients, this can be a PLR or bolus, obviously. In this instance, it's a PLR. And this will be a patient that didn't have a lot of movement or maybe even a diminishing stroke volume with more preload. So this patient likely would not be fluid responsive. However, on the right side, this patient actually had an increase of stroke volume when we did a dynamic assessment maneuver like the PLR. And this would be a fluid responsive patient. Again, we need to make sure we're meeting all the limitations before we make this analysis on our patient. All right, so let's get into bioreactants. So this is bioreactants, as you can see here on the right, is 4 non-invasive sensor pads applied to the thorax, creating a box around the heart. You can see the little box right here, right? And a small electric current of known frequency is applied across the thorax between the outer pair of sensors. A voltage signal is recorded between the inner pair of sensors. All the geeks out there, if you want to know, it's about 500 times a second. I think it's around 75 kilohertz. So that's about how fast it's going in. And that's the amplitude as well, the voltage, I should say. All right, the flow of the blood in the thorax introduces a time delay or phase shift in our signal, and we have correlated these signal changes to known thermodilution and cardiac output. So in study, we have learned this, and what they've done on particular technologies that use bioreactants is it has been teamed up against 65,000 patient samples in multiple clinical settings to gain accuracy, right? So that's what's been correlated to. All right, so let's get a picture of what bioreactance looks like as it's on our patient. So as you can see here, we have a signal moving in on the outer pair of sensors, and it's really just reading flow through the heart. So there's a lot of fluid moving through the heart, through the thorax, I should say. What we're looking for is pulsatile flow. So anything that's not pulsatile, it just gets ignored. So, and that kind of leads us to our contraindications, which we'll get to here in a second for this technology. But as we have a signal coming in, the inner pair of sensors takes that information, and takes it to our technology here, and we get a bioreactance wave that starts here. So how does that bioreactance wave start or form? If you look over here, please, as we're assessing the heart and the flow, we get the heart in different stages of flow as the heart's pumping, and we actually coordinate this little waveform, which is kind of cool. And then the area under that waveform is the stroke volume. So we're not looking at amplitude when we're looking at bioreactants. We're actually looking at the frequency of the waveform. So that makes it a little bit less prone to contraindications as well. Now, I should say there was an earlier technology that was called bioimpedance. I will say it was looking at amplitude, much like SVV or pulse contour. And I will say it had some contraindications, and they get really confused with bioreactance. So I really want to set the record straight that bioreactance does not have the same contraindications as bioimpedance. I think it's very important to know that. And it's a newer technology, and it's looking at frequency instead of amplitude, which really helps us with that factor. All right, as we can see down here, here's our phase shifts that are happening right here. So this is what I'm talking about, frequency right here. And this is, let's see how we can interpret this a little bit better. So as I have a baseline phase on my patient, obviously this is my baseline phase shift. And as I do a passive leg raise, what happens here? So this would be a patient that's possibly not fluid responsive, obviously, and this would be evidenced by stroke volume index or stroke volume less than 10% from that baseline on top, right? So we don't see a lot of movement here, and that's a problem. Likely this patient would go for pressors on this side. As we're looking on the patient on the right side, this would be a patient that's got quite a large phase shift over here. So this would be a patient that was likely fluid responsive, and we can probably be pretty safe to give this patient fluid if fluid is needed or warranted. All right, so that's all I had for you. That's my time limit. This is my references. And if you have any questions, please reach out to me, Clayton_Grigsby at Baxter.com. I do cover the whole Midwest, I believe all the way north to Minnesota, all the way south to Louisiana. I go all the way out to Arizona and Colorado, everywhere. So please reach out to me. I'd be happy to come to your facility and have further talks on fluid management. I appreciate you. Thank you so much. Bye.